Welcome, and thank you for joining us for today's session, Frequently Asked Questions on Smoldering Multiple Myeloma. My name is Christopher Peña, and I'm the Director of Educational Programs at the Multiple Myeloma Research Foundation. Today, we're really lucky because we'll be joined by Dr. Ola Landgren and Ms. Kelly Koubek from the University of Miami in Miami, Florida, and Ms. Jennifer Stone, a smoldering multiple myeloma patient living in Miami, Florida as well. They've agreed to join our live stream today and answer questions about smoldering multiple myeloma that we received from patients and caregivers after our most recent webinar on this topic. So without further ado, just want to jump right on in and talk to you, Dr. Landgren. Can we start with how people learn they have smoldering multiple myeloma? And in general, do they experience any kind of symptoms that are caused by the disease? So, for example, is someone with smoldering more susceptible to colds or the flu or anything like that?
So first of all, thank you very much for having me. It's really a great pleasure, and we love working together with MMRF. The question you ask is a very good question. And if you look in the literature would say that all the precursor conditions are asymptomatic. And for multiple myeloma, the precursor conditions are monoclonal gammopathy, or MGUS, and smoldering myeloma. So these are man-made definitions that have been developed over the past many years. So in 1978, the monoclonal gammopathy proposal was in the literature, the MGUS. And in 1980, for the first time, smoldering myeloma was proposed. And this was based on only 6 cases that were seen written up in a case report. And over time, people have thought about this a lot, and things have changed. But the basic principle is that these are not multiple myeloma. And multiple myeloma used to be a disease defined by symptoms. And over time, that has also changed. Back in 2014, we changed the diagnostic criteria. So you can also be diagnosed with multiple myeloma based on biomarkers. So the field is constantly changing. We're learning new things from different technologies. And as treatment gets better, things change. So the short version of the answer is that by default, you should not have symptoms. Now, the longer answer is there are people that have smoldering myeloma that could, because of the fact that you have these abnormal plasma cells in your body, that could lead to suppression of immunoglobulins, which is part of the humoral part of the immune system. And it could also have influence on the cellular side of the immune system, although that's probably less common if I think about all the patients I've seen over the past many years. But there are some individuals that have those type of things going on. And if that's the case, that could manifest in a higher rate of capturing infections. But I think for the most part, people don't have any particular symptoms. And what's definitely true is that there is no one single symptom that's indicative of smoldering. So smoldering is very sort of diffuse, and that's also actually true for multiple myeloma. And that, I think, very many times delays the detection and the diagnosis of many individuals.
Got it. And so my follow-up question, but I think I think you'd answered it already, was the same question but related to MGUS. And it seems that generally speaking, it is asymptomatic. Now, in terms of maybe susceptibility to infection, if that may be a little bit more common in smoldering, how is that for MGUS in comparison?
So the answer is the same, that the book would say that both MGUS and smoldering myeloma are 2 asymptomatic precursor conditions. But the reality is, as we talk about here, is a little bit different. So in some individuals, there is suppression of the uninvolved immunoglobulins. And that is because the plasma cells that are part of these diagnoses, the MGUS and smoldering myeloma, they live in the bone marrow next door to the normal plasma cells. And although we don't fully understand how things work on a molecular level, what we see is that in some individuals, these abnormal plasma cells that are making up the 2 diagnoses of MGUS and smoldering myeloma, they have characteristics that include that they can manipulate other cells in the bone marrow, including the normal healthy plasma cells. And the normal healthy plasma cells, they are normally making a lot of IgG, and they also make IgA and IgM, but IgG is the most important clinically for maintaining protection against infection on the humoral side of the immune system. So as these abnormal cells, if they become more active, and they do, interfere with the normal plasma cells, you can in some individuals see drops of the IgG levels. And I think round number, having looked at this for many years, in my experience, maybe 50 to 60+% of people with smoldering myeloma may have evidence of alterations in these labs. If you look every day in the clinic over many years, you can see that as a doctor. While in MGUS, it maybe is only 20 or 30%. Why is that? I don't think we really know, but one of my speculations is that the number of plasma cells are higher, and also on average, the activity of the abnormal plasma cells is a little bit higher in the smoldering category. So I think it's probably a consequence of volume and activity.
And you had mentioned, and we just got a question in the chat about IgA levels. And so is high IgA part of smoldering or MGUS, especially if you have like low IgG or low IgM? How does that all play a role?
So there are technically 5 different isotypes that have been defined in the literature. The most common is IgG. That is probably 70+% of all cases. That's true both for MGUS, smoldering myeloma, multiple myeloma. Second most common is IgA. That is probably most of the remaining cases, 100 minus 70, but most of them are IgA for the remaining. But there are a few IgMs. They are very rare, and there are even rarer IgD and IgE. They are very, very rare. And that includes all the ones that have monoclonal protein. Now, if you look in 1,000 cases of MGUS, 1,000 cases of smoldering, 1,000 cases of multiple myeloma, not everyone has an M spike. About 20% of cases, they don't have M spikes. They only overproduce light chains. So they could have either kappa or lambda overexpressed. So these are different isotypes, these are different types of protein secretor. So you could have either of them, and they don't clinically really have a very different trajectory from what we know in the smoldering space, which is what we are talking about here today. And usually not actually in myeloma or MGUS either, but there could be a lot of other perspectives on the detection, delayed detection, and things like that. But isotypes are really not known. So if you have an M spike that's IgA, that means that your IgA levels usually are elevated. If you have an M spike that's IgG, usually your IgG levels are elevated. And if you're in one of these rare categories of IgM, or IgD, or IgE, if you were to check the total IgM, D, or E in such cases, you would see that that also goes up. And that's because when you detect the immunoglobulins, if you look for, say, IgA, which is what you asked me, the body makes IgA, but if you have an M spike that's IgA, if you check for how much IgA you have in the blood, that includes both the normal and, if you have an M spike, the abnormal. So of course the IgA will go up if there is an M spike that's also IgA. And commonly you could see that the non-involved, which means the other ones, that they very commonly are suppressed. That's what I talked about when I said that increases your risk for infection.
No, that information is really helpful. And I think that segues into the next question, because there's a lot out there about the different types of isotypes. And I know we have a lot of patients that really want to keep track of their disease status. So Kelly, for those patients who hear a lot of this information and are hearing about the different isotypes and everything and looking at their lab tests, what should they really focus on?
Thank you for your question. And again, thank you for MMRF for including me in this discussion. So when patients are diagnosed with one of these precursor conditions, either MGUS or smoldering myeloma, typically we have a panel of set lab tests that we review and we monitor for these patients. And the frequency with which we monitor will depend on, the individual patient, what the diagnosis is. But we do have a panel of labs we monitor frequently, which includes a serum and these are all blood tests that we monitor, serum immunoglobulin level, which includes, as Dr. Landgren mentioned, like IgA level, IgG level, all the different immunoglobulins, as well as we look at the monoclonal protein level, which some patients will secrete and some patients will not, but we'll be able to detect that in a blood test as well. We also look at the light chain levels, both the kappa and the lambda light chains, depending on the isotype of smoldering or MGUS that these patients have. Typically, one or the other will be elevated. So we look at both of them again with the lab test, and we also look at the ratio of one to the other, the involved and the uninvolved. And then we have some other labs that we monitor as well, the immunofixation level, which again tells us a little bit about the isotype of myeloma they have. And then we also look at a complete blood cell count, which tells us if there's any anemia present, if there's any other white blood cell suppression, any other type of what we call cytopenias or drops in any of those numbers. And we look at a metabolic panel as well that looks at the kidney function as well as the calcium level, as we know both of these can be impacted when patients have active multiple myeloma.
Right. And I like to, think about this question for an actual patient. So Jennifer, looking at your routine blood test, that's how you discovered that you had smoldering multiple myeloma. Can you tell us a little bit about what that experience was like for you?
It was frightening. My primary physician had ordered regular blood tests in my annual routine, and she said their protein levels were abnormally high, so she ordered some additional tests, and they came back with something called an M spike, which I'd never heard of. So she said, I'm going to order an electrophoresis, and that came back with IgA monoclonal immunoglobulin. And she put a comment, unlikely multiple myeloma, but further tests needed. And I was terrified. I had to Google multiple myeloma. I did not know what it was, let alone smoldering. So then she put me on to Dr. Kazanjian, Dr. Landgren's associate, and we took it from there. And he explained really what it was. And I did more tests with the bone marrow biopsy and more blood work. So it was frightening.
And we'll go into a little bit more about the frequency of those tests and monitoring it in a little bit. Dr. Landgren, we're getting a lot of questions in the chat about risk. And we know that not all patients with smoldering myeloma are the same. Some may progress to multiple myeloma, others may not. And so really, can you summarize for us what the general risk for someone with smoldering multiple myeloma is to progress to multiple myeloma? What does that risk look like?
So the risk of progression, so that's a very good question. So I would say that the literature is probably overestimating that risk quite a lot, because what we started off talking about, you asked me about symptoms. What would lead someone to identify smoldering? If you don't have symptoms, why in the first place is anyone worked up? And why did you find it? So I think there is a bias in that sense, that people that are worked up are usually worked up for other reasons. And when other things are being done, sometimes part of the workup leads to the unplanned discovery of smoldering myeloma. It could be someone who has an infection, a history of infections. It could be someone who has, say, neurological symptoms. It could be someone who signs up for life insurance or other things. So if I look through my charts of all the patients that come to me over very many years, why did they end up coming to me with a diagnosis of smoldering myeloma? It's usually because they were worked up for something else, or life insurance, which is less common, relatively speaking. Usually it's a medical condition. Rheumatologic disorders could also be part of other autoimmune disorders. So I think that there is a bias in that on average, people that are worked up for other reasons and found to have it, they end up in the databases. So when you follow them over time, their risk is probably not the same as the risk in someone who was found in a screening study. And I know that firsthand because I'm the co-PI for the Icelandic study, and we worked on that for many years. And we looked at the risk of transformation. We also looked at the prevalence of smoldering myeloma. And we actually found very different numbers when you screen for these conditions. So basically what I'm saying in simple language is that if you just screen and you find it in more people, there will be many people that have a very, very low risk. So the risk that's in the literature suggests that if you see the smoldering the first time, but it could be as high as, say, 10% in the first year, and then you check again, and if you look at the curves, it could continue to be another 10% the next year. But if you follow people for a few years, the risk seems to level off. So if it doesn't declare itself it's probably not going to declare itself. And there are studies that we call retrospective studies, which means that we have all the data and we go back and look at things in the past, and then we go back and forth. Those studies are always biased because of all these things I'm talking about. So really, if you want to get a really good answer in science, in clinical science, you have to set up a study and follow things prospectively. But that's much more difficult. It takes much more time. It takes more resources to do that. You have to screen people. You have to follow them prospectively into the future. And that's what the Icelandic screening study does. So if you look at the old retrospective studies, most of them are done by Mayo Clinic. They are sort of the powerhouse for retrospective studies, and they have done many of them, and they can be quite useful to get some leads, but they have the bias of overestimating things because of bias of people who are in the databases. So they would say that it could be as high as, say, 50% for someone from the initial diagnosis in the first 5 years. If you look in the Icelandic study, the study is not yet fully published, so we don't have the final data, but looking at the ongoing study, I think it's going to be at least half of that. So I think the risk will turn out to be much lower than we think. Now, that being said, there are some cases that have a higher risk of progression, and there are certain features that we know could put an individual of higher risk. So I started off saying that all these definitions are man-made, and we don't have really like distinct tests to say this is myeloma, this is smoldering myeloma, this is monoclonal gammopathy. These are thresholds, these are numbers. And in 1980, someone said if it's over 10% of cells in the bone marrow, when I look in the microscope, that's smoldering myeloma. If it's less, it's monoclonal gammopathy. So how do you know 10%? If 10 people look in the microscope, someone says 10%, someone says 15%, someone says 20%, someone says 5%. So these are very imprecise. And even someone could say 9%, or someone could say 11%. So that could make a huge difference for what is what. So the same is true also when you measure these proteins in the blood. They are very imprecise. They are very non-reproducible. You could even go the same day, you could go to 2 institutions and do blood draw. You could get different results because the machines don't do the same. They don't work the same way. They're not calibrated the same way. But given all these caveats, take them aside and say, it is what it is. If you work someone up and you have a higher number of cells, higher number of M spikes, there are more suppressions of the animal immunoglobulins, there are more elevations of coexisting light chains. Maybe there are some people that could even be over 20% risk of progression on an annual basis if you look in some of these studies. But the flip side is also true that there are people that probably the risk is 1% per year on average. And they are still labeled as smoldering myeloma. So the more you know about these things, the more you know how inaccurate and how imprecise they are. So I think one of the biggest missing pieces in the whole puzzle right now is precision tools to really predict the individual person's risk for progression. We don't have that. It's just probability. So we have groups of patients that fall into categories: high risk group, intermediate group, and low risk group. But
I'm sorry, go ahead.
Within all those groups, there are both progressors and non-progressors. So even if you think about an example that we have 100 people in a high risk group, say 20% of them could progress in 1 year, you could say, wow, that's a high number. While in a low risk, maybe it's only 1 or 5 people per 100. Say that's a very low risk. That's of course true, but the issue is that no one knows if they are the person that's going to progress or not. So it's a probability game. So it's not like a pregnancy test. If you ask, am I pregnant? Yes, no. It's a probability game. So it's very, very different. That's what we miss, right? We need those types of tools.
And it's true. I'm glad that you provided that context, because I think from time to time, people may look at what is out there and what things may say, and it may say, okay, 10% per year for the first 5 years. And then they'll think in their minds, okay, well, 50% get it. But it's nice that you share the context in which those numbers are derived from. And I think that for a lot of patients, that can be settling and good to hear compared to just looking at just numbers in a black and white sense. Is that fair to say?
Absolutely. And I think ultimately where science will take us is that we could even say that very few things in life are 100% or 0%, but it's 99% or 1%. So the people that are progressors, I think with better tools, we can probably identify them much earlier. And that will say that this is someone with a 99% probability of progressing, or someone who has a 1% of progressing. That's someone who, I mean, there are a lot of other competing risks in life. Like if you travel with a subway, if you live in a busy city, or you drive here in Miami on the highway, that's probably more dangerous than have a low risk of these conditions if you think about all the competing risks in life.
Got it. And so thinking about some of these other ways of identifying and pinpointing smoldering multiple myeloma, we've had patients ask if there's any kind of correlation between smoldering and other comorbidities or any kind of relationship that can suggest smoldering. So we've heard questions about amyloidosis, myeloid dysplasia, non-Hodgkin lymphoma, arthritis. Is there any kind of correlation between that smoldering and those other kinds of comorbidities?
So your question is if there's a correlation between amyloidosis and smoldering myeloma? Right,
exactly.
Yeah, so the very little scientific data is available, but there are, as I'm sure you know, studies showing that amyloidosis, to begin with, is an umbrella terminology with about 30 different conditions that go under that umbrella. And clinically, they are completely different from each other. Even diseases that have absolutely nothing to do with myeloma and plasma cell disorders are technically amyloidosis diagnosis. I think the most prominent is probably Alzheimer's disease. That's absolutely nothing to do with plasma cell disorders. There is zero correlation, but technically that's an amyloidosis disease. The light chain amyloidosis disease is very, very separate from all the others. That's more related to multiple myeloma. So, but it's still called an amyloidosis disease, and it refers to the fact that there are protein structures that are deposited into tissues. So that's sort of what amyloidosis means. So a lot of words in the medical literature that are just like describing what you see. And there are many people that have multiple myeloma that also have a subset of plasma cells depositing misfolded proteins that go into the heart or the kidneys or the gut or other organs. The same is true in smoldering, and the same is also true in MGUS. There are some people that just have these cells depositing these proteins, and they don't fulfill the criteria, neither for MGUS, smoldering, or multiple myeloma. So there is some form of a link, and all these conditions I mentioned, AL amyloidosis, multiple myeloma, smoldering myeloma, monoclonal gammopathy, or MGUS, all these are plasma cell disorders. But the relationships observationally are there, but we don't fully understand the biological underpinnings. We really don't.
Well, thanks for sharing that. And I think now, since we've talked a lot about diagnosing multiple myeloma, I want to shift gears and talk about monitoring and treatment. So, Dr. Landgren, what is the standard for managing patients with smoldering myeloma?
So, February 19 of 2025, today's date, the standard of care is monitoring, and that would include the initial workup. If you discover this protein in the blood, if it's a monoclonal protein, if it's elevation of light chain, or a combination of the two, usually it would include or should include a bone marrow biopsy, and should include advanced imaging. That should be a minimum of a PET-CT in the United States, and usually, if there are questions or additional comments, maybe also on whole body MRI without contrast, but at least blood work, bone marrow biopsy, and a PET-CT. And once you have established that and you show that this is not multiple myeloma, you basically rule out multiple myeloma, but you then also confirm the smoldering diagnosis. The guideline would say, these are clinical guidelines. I've been one of the authors for many years writing these guidelines, and we have kind of shared opinions among all the groups to repeat the labs every 3 months. And if you do that for a year and you see there's really no trend, you could do another 3 months for a year. So 3 months, 3 months, 3 months, 3 months for a year. Or you could start thinking about 3 to 4 months. It depends on what you see. And if you didn't do 4 months the second year, maybe you do that for the third year. And you do for a 5th year. And then we wrote in the guideline, if it remains stable after the 5th year, you could even do 4 to 6 months. In my experience, many times questions come up, do we really know that there are no changes in the bone marrow? Did there show up any other things in the body that the blood work didn't reveal? So before you start stringing out longer interval, in my clinical experience, many times we could consider repeating a biopsy and do another round of imaging to build confidence that there is really no change. And if you continue monitoring for beyond the 5 year, if you do 6 or 12 month long term, you could, if you see changes, of course, ask your question if you should repeat the labs soon again, and or if there's a reason to do imaging and a new bone marrow biopsy. If there are any symptoms, that would also prompt that. So that's sort of the basic for where it is. And when it was initially described in 1980, based on these 6 cases in the case report I mentioned, it said explicitly in this case report that smoldering myeloma does never need to be treated. It said in one sentence, but that was the first time they saw these 6 cases. So how did they know for the future? And it took almost 20 years for the first randomized trial to be done. And it was based on very old therapies with chemotherapy. And that study was published in 1996 with melphalan and prednisone. And they found no evidence of improved progression-free or overall survival. So the whole idea was sort of put to rest that, no, we should not treat that. And for many years, people were thinking about it. And in 2012, the Spanish group published the paper in the New England Journal of Medicine where they gave newer drugs. They gave lenalidomide and dexamethasone or Revlimid and dexamethasone versus monitoring. And in a quite small study, I think there were 60 patients in the treatment arm and 60 in the monitoring arm. They showed there was a significant improvement in progression-free survival. And later, they also showed overall survival benefit. So that triggered a whole slew of initiatives. So we started a study when I was at the NCI, adding carfilzomib to lenalidomide and dexamethasone. And after that, Mayo Clinic, they wanted to copy that, and the Spanish wanted to copy that too. So the Spanish copied the same carfilzomib, lenalidomide, dexamethasone, and they added transplant. And Mayo copied it and added daratumumab. So all of a sudden, there were 3 different initiatives going with quite intense treatments. The first study, the NCI trial, we published many years back ago, that study showed that if you treat for 8 cycles, 2 years of maintenance, stop the treatment, in long-term follow-up, 8 years later, 70% of those patients remain MRD negative. They're free from disease. They probably have been cured. But what we will never know is if there were patients in the mix that would not have progressed anyway. And that is the forever question that we don't know the answer to.
Well, I'm gonna step in there because I think that that's a really interesting point to bring up about patients knowing or not knowing. And Jennifer, I want you to be able to speak to your unique experience in terms of how it was different for you for watchful waiting. So how did you learn that your smoldering myeloma was high risk, and how was the option of a clinical trial presented to you in this case?
Well, I met with Dr. Kazanjian and Kelly. This was maybe 2022. And they described the watch and wait process. And I was a little bit in disbelief because if you have a precancerous cell on your face, the dermatologist takes it off. So I said, I'm really not that comfortable with watching and waiting. What can I do? Is there something you can give me before? And Dr. Kazanjian described some upcoming clinical trials. And we continued talking about them while they monitored my blood. We did some bone marrow biopsies over the years. And I started a trial on December 2023. Yeah, watching and waiting is and the name of it, smoldering myeloma, is a little, so it was described and I agreed.
Got it. And so just in terms of getting support, how was that like for you during that particular time?
It was fantastic. Kelly, the entire team at Sylvester really, really explained. They have calmed me down when I didn't know what to do. They walked me through the bone marrow biopsy, which was not that bad. They explained the numbers. They had to draw little diagrams. Dr. Kazanjian drew a little diagram when I didn't understand what he was telling me. And now I understand. So the support is amazing, absolutely amazing. And I can reach them at any time I need to if I'm having, thoughts and worries about something. So I'm in really good hands. Thank God.
And Kelly, I think this is a great question to ask you. I know Dr. Landgren was talking about some of the frequency of these tests for smoldering patients. And so from your perspective, how often are patients with smoldering multiple myeloma seen, and what should they generally expect as far as lab tests go? So for example, if bone marrow biopsy, is that part of every follow-up, or what about like a whole dose MRI or low dose CT scan? And now we're getting questions in the chat, is one better than the other? So I'm happy to hear your thoughts on all of that.
Yeah, that's a great question. And it kind of builds off what Dr. Landgren was explaining earlier. Typically, when these patients first present to our clinic and we suspect the diagnosis of smoldering myeloma, what we want to do is fully rule out anything that would categorize them as multiple myeloma. So we do the full panel of blood work that I had mentioned earlier, as well as we typically will do a whole body PET CT to rule out any bone destruction or lytic lesions that would categorize the patient into the myeloma diagnosis. And then we'll also do a bone marrow biopsy at that time, basically to quantify the number of plasma cells or abnormal cells that are in the patient's bone marrow. And depending on that number, and again, as Dr. Landgren said, these are somewhat man-made definitions, but depending on that number, that can change the diagnosis. If it's less than 10%, typically the patient is asymptomatic otherwise, that would place them in the category of MGUS, versus between 10 and 60% plasma cells or abnormal cells in the bone marrow fits within that smoldering myeloma diagnostic criteria, and then greater than 60% could mean, a diagnosis of myeloma. So we do all of that at baseline for these patients that have smoldering myeloma, basically to confirm to rule out multiple myeloma. In addition to that, often we will do a whole body MRI too, and that is again in favor of ruling out multiple myeloma. Another way that can potentially diagnose a patient with that is the presence of any focal lesions on an MRI. So it's not really that a PET CT or an MRI, but one is better than the other, more that they complement each other in the way that we diagnose these patients. So often that will all be done at baseline. And then typically, as Dr. Landgren mentioned, as we follow these patients, usually it's every 3 months would be the interval, at least starting out. And we don't do bone marrow biopsies and PET CTs every 3 months. We typically will monitor with blood work, and based on how the patient is feeling. So if we see that the trend over time, the blood work is very consistent, there's not any increases, things are very stable, and the patient is feeling well, then we'll typically continue to monitor them at that frequency of 3 months, maybe expand it out or lengthened out depending on the stability of the patient. But we wouldn't get a bone marrow biopsy or subject a patient to a bone marrow biopsy and a PET CT that often. We would maybe get those tests again if we suspected there was maybe some progression to myeloma based on blood work or based on how the patient is feeling. If there was any sort of indication that now we suspect this has progressed to myeloma, then that would be the case for us to get additional testing to, again, kind of rule in or out that diagnosis.
Great. And so just to follow up on that, and we hadn't mentioned it earlier, but the 22-20 criteria in terms of risk stratification. First, I would love to hear your thoughts on that. And secondly, if risk is given at that initial point, does any of that testing frequency or those tests change if somebody's categorized as like high risk or low risk?
So the 2220 is, these are the guidelines per the Mayo group of categorizing patients as low, intermediate, or high risk. And the 2220 refers to the percentage of plasma cells or abnormal cells within the bone marrow biopsy greater than 20%, the serum monoclonal protein or M protein that we measure in the blood greater than 2, and the light chain ratio also greater than or equal to 20. So those are the three, that's the 22 and 20 that they refer to within that model. And this is just one of the ways that we can kind of categorize patients as high risk, so to speak, lower intermediate risk. It doesn't necessarily change as far as the monitoring of every 3 months. We really do try to individualize the approaches for these patients too. But typically it's just kind of something that we are aware of at their time of diagnosis. We know that they may be, based on this model, may be what's considered higher risk for likelihood of progression to multiple myeloma. But as Dr. Landgren mentioned, there are other factors and other things at play too. So it's not just it's not just this that we look at. We look at the whole picture and we look at everything in totality when we think about a patient's risk. But it doesn't necessarily mean that we will be monitoring these patients any more frequently, because a patient may be deemed high risk by this model, but if they've demonstrated stability over 5 years' time, as Dr. Landgren said, then their disease has been, it's been stable for that amount of time, and they wouldn't require any additional monitoring or anything. So I think that sometimes is more telling than these risk models, is the stability over time of the patient's labs and how they're feeling.
Great. And so to follow up with that, Dr. Landgren, when do you get concerned if someone has progressed from smoldering to active? What sort of raises the flags, in your opinion, that has happened?
Well, so when we monitor someone who has smoldering myeloma, we follow the paradigm we were outlining here, Kelly and I. And if you look and see how the definition for multiple myeloma has been crafted out over time, I mentioned it used to be symptoms, and that would be skeletal symptoms or anemia symptoms or renal symptoms or hypercalcemia symptoms. So that's usually when the disease is a little bit more established, if you want. But over time, the past 10 years or so, the criteria for myeloma include biomarkers. And the specific biomarkers are the number of plasma cells in the bone marrow using the microscope, also checking the concentration for the light chains in the blood. And lastly, also the use of MRI. If you can pick up 2 or more focal areas, although the person may not have symptoms, that could still make it the diagnosis of multiple myeloma. So we, of course, have to follow the diagnostic criteria. So we have 2 jobs. So one is that we deliver top-of-the-line healthcare, and the other job is that we're trying to drive science forward and learn new information and try to solve problems where we don't have the answers to. But when we are practicing medicine every day in our clinic, we have to, of course, make sure that we stand on the same legs as everyone else. Otherwise, it will become very chaotic. And if there are areas where we are trying to test new things, that would always be on a clinical trial. You asked me before what standard of care is, and I said the standard of care in February 19 of 2025, I said is still monitoring. And I said that these were the trials that were done. I wanted to also add to that and say that I think the field will change, and it will probably change in 2025. And at the same time as we developed these 3 drug combinations that we did over 15 years ago when I was at the NIH, and then we had a Mayo Clinic and the Spanish doing these studies I mentioned, the first reaction that we got from other people, other investigators, they basically said to us, this doesn't work, and I think even people said it was stupid to do it. But when we showed that 8 years later that 70% of patients were free from disease, people said it was actually pretty good. But the question was, do you really have to give so intense treatment? So these were pretty intense treatments. So what has happened over the past several years now is that people have tried to give less intense treatment. And in 2010, we published, actually 2020, we published this study that was based just on daratumumab or Arcellx. And this year we published a follow-up 10 years later on just staying on Arcellx. And all this work triggered the Aquila study. That's a large randomized multi-center international study that compared Arcellx to monitoring. And that was published in the New England Journal of Medicine in the end of last year. And that study showed that even with a single drug, Arcellx, that you could have a better progression-free survival in the smoldering space. That study is now going to the FDA for their ODAC meeting. And they're going to vote on that in about 2 months, according to the internet. We'll see if that's going to happen. But there is a very high likelihood that ODAC, I think, will vote yes. And if they do, then the FDA have to make a decision. They usually go with the ODAC committee. So if the ODAC, the Oncology Drug Advisory Committee, says yes, that means that now we have, for the first time, an approved drug for smoldering myeloma treatment. So I just want to add that to the whole conversation we had. We have built on that. I was the lead author for the Centaurus trial. That was the study that led to the Aquila trial. And I was also the chairman for the Independent Data Monitoring Committee for the Aquila trial. So I followed this for all these years very, very closely. So based on that, we developed the Revive study here in Miami, where we give daratumumab with teclistamab. Instead of giving it forever, we wanted to do 2 effective antibodies that we give once a week for the first month, and then we give them once a month for 2 years. And we are targeting to have a very high rate of the patients free from detectable disease, same way as the NCI trial. So there are sort of 2 schools of thought here. So if you want to go after the disease, you can do these more combinations with more intense treatment that we did years ago. But the evolution now will probably be that there could be an FDA approval for a single drug that will hold the disease, but it will not eradicate the disease, or maybe add a second antibody, which is what we are doing. So this is the only study in the world right now that has it. Dana-Farber has the antibody teclistamab, but we have both Arcellx and teclistamab here. And I think there may be other studies coming. If we monitor people for just like standard of care, we will look to see if someone develops myeloma criteria. That would change the diagnosis, and that would mean that we would not offer treatment for multiple myeloma. But I think we will see both these 2 things happening in parallel with the new evolution of anticipated FDA approval later this year, which is sort of a big milestone for the whole field.
Well, that's really exciting news, and we were going to get into some question about some clinical trials, but I think that that's really interesting to hear that there's some combination therapies as well that could be highly effective. So thanks for sharing that with everybody listening. Kelly, we did get a question, and I wanted to ask this to you. In terms of your experience, is progression from smoldering towards active, when you're considering that, does that happen gradually over time, maybe over like 5 years, or can it just spike within a very short period? What have you seen in your experience?
So that's a great question. And I would say that's one that we get a lot from a lot of our patients, because they want to know, of course, is this going to happen quickly? Is this going to be something that will happen over time? And the answer is really that every patient is different, unfortunately. So we don't have a great answer for that. That is why we monitor these patients so closely with the labs every 3 months, because the idea, which of course we could do more frequently if we felt that that was clinically warranted. But the idea is that we're monitoring so closely so that we are able to catch it before it is, something that has, gone out of control, or things have gone haywire, and now the patient is symptomatic and has, many symptoms from the myeloma itself. But the short answer is that it really is different with each patient. But with close monitoring, usually we are able to, in what my experience that I've seen, and I'm sure Dr. Landgren can speak about this too, with close monitoring, we are able to, the idea is that we're able to catch it before it becomes out of control, so to speak, or something that we need to urgently intervene with treatment.
Got it. And so kind of pivoting a little bit, in terms of patients, we get a lot of questions about lifestyle and dietary habits in terms of reducing the risk of progression from like smoldering to active. So are there any exercises that can help, or foods or dietary supplements to either take or avoid, anything along those lines?
Well, maybe I say that both Kelly and I came from Sloan Kettering, and one of the junior attendings I hired was Urvi Shah when I was at Sloan Kettering, and Urvi was very interested in food, so we started developing ideas. And after I left, she continued working on it, and I'm really very proud of Urvi for all the work she has been doing and she is doing. So the work.
Nutravention, by the way.
Yes. So
yes. Okay. We just got a question about it. So what are your thoughts on Nutravention?
So I remember sitting with Urvi. She was a fellow. She was sitting in my office, and she wanted to do science, and she didn't know what to focus on. And I asked her what she was interested in. She said, I'm interested in food. So we talked about maybe we could do something around food. So she started working on a protocol. This is like 10 or more years ago, and she didn't have any grants. So I said, I will help you. I will give you some funds. And we bought food from a company in Brooklyn with plant-based food. And then we started measuring biomarkers, and then she kept on developing, and I moved here to Miami, and she kept on developing her own program. So she should have all the credit for all the work she's doing. But it started really as like just an idea. It sounds interesting, and that's how a lot of things start. So what she has done herself is that she has worked with investigators in New York to measure biomarkers of the immune system. And she has then continued with these plant-based foods, and she has found that you can modulate the level of inflammation or immune stimulation in your body, and you can also change what's called the microbiota in the gut. So we all walk around with a lot of bacteria inside our bodies, and most of them live in our intestinal system. And they're different in different individuals, but there is a balance between these bacteria that make us healthy. But if we eat certain types of food, or if we do certain things, or we take different type of medications, or we have certain diseases, this balance could get shifted. And that's really the idea, that if you can eat more healthy food, plant-based food, that you can shift that bacterial balance, and you can see that there are changes in the bacterial makeup, and you can also see how these immune markers actually go down. What is not 100% clear at this time, and it's going to take time for Urvi to show that, is how that potentially could impact clinical outcome for disease. You need large numbers of patients followed for very many years to have really strong data. I should say that there are other groups that are looking into it, and we are trying to do the same here in Miami. So we probably will open in 2025 a Mediterranean food-based study, because we believe that that type of diet, there is scientific evidence for that. And there is also something called clock genes that translate into, so you could have some fasting periods, so you eat for not some hours, or you do or do not eat. And some genes in the body they seem to be impacted by the timing of food intake, so what you eat and when you eat. So we are working to develop a study, and Urvi is a very good friend of mine, so we of course are going to share the data, and we hope together to help each other and advance the field. So that's how it goes.
Great. And you had mentioned Mediterranean diet, so just wanted to follow up. What evidence has there been shown between that and cancer risk and so on and so forth?
So I don't have all the references handy, but I do have PhD dietitians on the team, and we have carefully gone through the literature, and there has been a lot of research in different diseases. I know for sure in breast cancer, that has been a big area of investigation, and that's also where you can see these clock genes. What that basically means in practical language is that instead of eating late in the evening and eating early in the morning, that you have a little bit of a break, so you eat and then you don't eat until some more hours, or you stop eating a little bit earlier in the evening, so you give the body a break. And I think in breast cancer, there was some studies showing that that could have prognostic implications. We are trying to see if we can use those studies and learn, and maybe do a study where we could check, say we do a blood test, and we can see if those genes get impacted, and see if that also could have influence. So it would be beautiful if food could become medicine, right? Everyone would like that.
For sure, for sure. So you had mentioned earlier talking about some of these combination therapies, and I was just wondering if in any case there would be a situation where a high-risk patient, or even just somebody of standard or intermediate risk, would not be eligible for those kinds of medications, or eligible for anything like that, or a clinical study. What circumstances tend to be there that would preclude somebody from getting those treatments?
So you're referring to the different trials, if someone has...
Yeah, the trials. Yeah, if somebody is not eligible, what is it, like what would not make them a candidate for like a clinical trial?
Do you want to answer that, Kelly?
Sure. So the clinical trials that we have, or the clinical trial that we have specifically that Dr. Landgren was speaking about here at University of Miami, is meant specifically for patients that have what's categorized as high-risk smoldering multiple myeloma. And again, there's the trial is unique in that it captures patients in that high-risk group outside of maybe some of just the traditional models. So there's the Mayo 2220, which we spoke about. The Spanish group also has a model that's used to determine if a patient is high risk based on some of those biomarkers that we had mentioned. But the trial is actually unique in that it casts somewhat of a wider net, in that it allows for other factors that we know clinically may make a patient higher risk that are not accounted for within those models. So it's designed for patients that do meet that high risk category versus those that would be considered low or intermediate risk. As a general rule with clinical trials across the board, and this is not just for smoldering trials, or not even just for multiple myeloma, but for clinical trials in general, there's always inclusion and exclusion criteria criteria that every patient has to, meet in order to be enrolled in the trial. And that inclusion and exclusion will vary from trial to trial. But the goal for every clinical trial is to make sure that we're treating patients safely, making sure that we're doing what's best for the patient and what's right for the patient. The trials are designed for a certain group of patients. We want to make sure we are targeting that correct group and we're doing so in a safe manner. So if patients have other comorbidities or other conditions that may make it unsafe for us to give these drugs, those would typically be the things that could potentially exclude them. We always want to make sure safety is our top priority. And so we always want to make sure what we're doing is safest and best for the patient. So it will vary from patient to patient, or from trial to trial, excuse me, but typically anything that would make it unsafe for us to treat those patients would be the things that would exclude them.
Right. And what about for patients, let's say that we do get a lot of people that just really want to treat this, that the smoldering diagnosis is just something that causes a lot of stress and a lot of anxiety, and it's very much an impetus just to try to deal with the disease or to treat the disease. What would you suggest for those individuals?
I would say for those that are looking for treatment, of course, that we do have these clinical trial options, available to patients that are looking to play an active role in treating, and we do offer that to patients if they are interested. Of course, we don't push it for patients that are not. There are some patients that prefer the watchful wait approach, and some that want to initiate treatment right away. So we are, as a major cancer center and a research center here at University of Miami, we want to be able to offer those kind of cutting edge therapies for patients that are interested. I think another thing is, I know it can be watchful waiting can be unsettling for some patients and can be something that maybe they're not completely comfortable with. I think also providing reassurance always is part of our job too, that even if they're not on active treatment for whatever reason, if they're not wanting to be on active treatment, or maybe they're not eligible for a clinical trial for any reason, reassuring them that watchful waiting is not doing nothing. It's keeping track of things. It's close monitoring. It's seeing us for follow-up. It's getting lab work. So it's not sitting back and doing nothing, even though it may feel like that at some points for them. We're keeping an eye on things and making sure that we're very closely monitoring. So I think that's just providing that clinical reassurance, making sure when we meet with these patients, we're going over the labs, we're providing all the information. We're always being upfront about what's going on. If there's changes in the lab work, being very upfront about any changes or anything that may be of concern to them.
Got it. And I think that's something really valuable we could share with everybody listening, that it's not just sitting back and watching. There's a lot of proactivity that goes into this. So thanks for sharing that. Jennifer, I'd love to just hear your thoughts as someone who has participated in a clinical trial. Can you tell us what that experience has been like for you, and specifically what treatments you are receiving, and how often do you come in for testing and whatnot?
It's been a good experience. I didn't know what to expect, but I'm in the clinical trial with daratumumab and teclistamab, so the dual injections. And for the first 6 months, it was once weekly, and now it's once monthly. So I go in and I have blood taken. And by the time I get to Kelly's office, she has some of the results, and then I go for treatment. And it's 2 simple injections in my abdomen. It's easy. The nurses know what they're doing. It's not as disruptive as one might think, and we've seen results from it already. I'll let Kelly say what results we've seen, but the bone marrow biopsy was the crowning, the icing on the top, the last one. So it's a good experience. So that's about it.
Great, awesome. Now that was my follow-up question, just how your lab results have been since participating in the trial. So that's awesome to hear. In terms of just the clinical trial itself, like impacting your lifestyle or anything along those lines, has that had any kind of effect or anything like that?
It has not. I'm lucky. Where I work, I have sick time, and it just takes a day. And luckily, I don't have many side effects, just skin sensitivity. So it has not affected my life at all. There was some fatigue in the beginning, but it was probably just my anxiety doing that. It has not affected my life negatively. In fact, my mind is calmer now that I've seen it's actually working. So I don't have an M spike anymore. I don't have bad cells in my bone marrow anymore. And this was, I started in December 23. And as of April 24, I had no errant plasma cells in my bone marrow, which to me is astounding. So it's hopefully one day, this in the years, Dr. Landgren can, do more trials, and maybe this can be an over the prescribed injection, a take-home injection, like so many medications are now, so that nobody has to get multiple myeloma if you start with smoldering. That would be like a game changer. Because if it works, it works. Nobody wants to have it. So, that's my wish for the future.
And we had a question from the audience for you specifically. How long were you smoldering before you made the decision to enter the clinical trial?
2022, and I signed up about a year and a half when this trial was approved to come through. So a year and a half, I did the watch and wait, and my doctors took my blood and monitored me. And we always spoke about the upcoming trial, and I think I called first and said, let's go, let's start. I'll be the first, I don't care. And it works. I'm astounded that the bone marrow came back with no cells. I didn't believe the nurse doing the bone marrow. He said there's going to be nothing. And indeed, there was nothing.
I love hearing about these great results in your experience. So if you could just give advice for any patients who may feel apprehensive or stressed about their diagnosis, what would you want to say to them?
I'd want to say, look for a clinical trial that you can get any of the treatments in, whether it's Dara on itself or any combinations. I went to us.gov, I think, US trials. And then Kelly and Dr. Kazanjian told me about the trial. And I looked for them and I read each one. And I started to read more about the treatments and Dara and what it does. And I think I was just in the right place at the right time. Sylvester is absolutely wonderful, and everybody should come here if they can. Looking at trials actually helps a little bit, and reading about the drugs actually helps a little bit, because then I was encouraged by reading the past trials on them. And I read a lot of Dr. Landgren's papers as well. All the publications I follow. It helps. So I'm going to
what's the name of I'm sorry, go ahead.
Go ahead. No.
I was going to say, what was the name of the trial that you were on?
Revive, Kelly?
Yes.
Revive.
Yes.
Revive.
So the name of the trial is it's our Revive clinical trial. Jen is one of our superstar patients who's done extremely well. As she said, she's wonderful. She was one of the first patients to enroll to the study, and she's had an excellent response, and she's just been doing so well. And we're very proud of her. I'm very happy for her with the results. And because she was one of the first patients on the trial has actually been amended or updated since Jen initially enrolled. So when it was first started the trial, it did involve the weekly injections that she referred to for the first, a certain amount of time that she was, the first few months that she was on the trial. It has since been amended, and now the weekly injections are only for the first month, actually, and then it just goes to once a month. And we found that patients, makes it much easier for them. One of the things, the hesitations that people often have when starting treatment is the commitment to coming in for treatment. It is a commitment. And it is something that, if you have to be here weekly, it's something that can be, something that it can be a deterrent for patients to proceed with treatment. So it has been amended since that time. So it's just weekly for the first month. And then it's just monthly after that for the 2-year duration of the trial.
So may I add something to that, Christopher? So we worked on the dosing, as Kelly outlined, and we talked extensively both to J&J, that owns the 2 drugs, and also to the FDA. And I wanted to go to the monthly dosing. And after we went through all the data back and forth, both the FDA and J&J approved it. So to do once a week for one cycle, which is 1 month, and then do once a month thereafter for a total of 24 months. We have people who come from very far away. So the downside is that you have to spend 1 month in beautiful Miami, and then you have to come here once a month for the rest of those 23 months, which is not too bad. And we have people coming from very, very far away. And what we really would like to do, what I would like to do as a leader for the program, is to make sure that we can establish a curative treatment for the disease. So I cannot 100% promise that this will do that, but building on what we did at the NCI when we gave the KOD regimen, we showed that 8 years later, 70% of patients have no detectable disease. With these new treatments that are over 10 years newer, the efficacy of these seems to be amazing. So I hope to see that there will be many patients many years out that will have no detectable disease. We cannot 100% promise that. That's why it is still a study. But that's really what we are trying to do. So we're trying to really turn the needle here and shift the field towards trying to get rid of the disease. That's what we want to do.
Right. And I think the perfect way that we could end this is for those patients that are really interested in a clinical trial, or maybe they want a second opinion. What advice would you have for somebody who wants to go down that route?
Well, I think depending on what's feasible for the individual, if you live close to a specialist center, maybe go there for a second opinion. If you're interested, you have the ability to travel. That could be specialists elsewhere. We never say no. We welcome anyone who want to come and see us. We're always here to help, and there are never any strings attached. We can go over everything, and all the doors are always open. If someone want to stay with us or keep us as a quarterback and have a local team, that's also perfectly fine. And I know there are a lot of other good groups around the country. So we are always here to help. And we have almost 10 faculty now, and we have a very strong research program. So that's my answer back to you.
Great. Thank you so much. And so I think this is a really good stopping point for all of us. So on behalf of the Multiple Myeloma Research Foundation, I just want to thank Dr. Landgren, Ms. Koubek, and Ms. Stone for joining in today. I think this was really impactful for a lot of patients. I also want to thank everybody out there listening for sending your questions and taking time out of your day to watch. If you're interested in learning more about clinical trials for smoldering multiple myeloma, there is a clinical trial finder on the MMRF website, and we'll be pasting that link in the chat. Also, the study that Dr. Landgren mentioned again is the REVIVE study, and we'll be sharing that link with you as well. And in addition, if you need help with the clinical trial finder or have any questions today that we were not able to get to, or you just have some more that come up, or you just want to learn more, please call our MMRF Patient Navigation Center. That number is 1-888-841-6673. And they can definitely help you with any of the material that we covered today or any questions that we just didn't, that we weren't able to get to. And last but not least, I want to thank Adaptive, Amgen, BMS, Cure, Genentech, Johnson & Johnson, Kite, Arcellx, and Pfizer for sponsoring this really helpful session. So thank you everybody for joining, and we hope to see you again soon. Take care.
Thank you so much for having us.
Thank you.
Thank you.
Hi, guys.